Thank you to the Anterior Hip Foundation for inviting me to speak. I do have a PhD in biomechanics. This is not what this talk is about. It's about billing, so I hope you all don't run away or fall asleep. Today we'll be talking about how I can bill for all this preoperative work. My name is Eytan Debbi. I'm a hip and knee surgeon at HSS, and thank you for inviting me. So I have some disclosures, but none of them are related to this talk at all. I'd like to give thanks to a few of these individuals here, namely Alex Saw, Mike Ass, and Brian Springer, who have given this talk before. And I have to say, I try to shy away from billing as much as I can in terms of my practice. But at the end of the day, I think if we really want to make sure we're getting paid appropriately for all the work we do, I think it's something that each and every one of us has to at some point sit down and actually go through what the codes are paying us and how to appropriately bill. So we all know this, our reimbursement, especially for Medicare, continues to go down, and it kind of feels like this race to the bottom. And I think this is a topic for discussion separately, but it really drives a lot of the stuff we do. But at the same time, we know that same-day discharge and ASC surgery is on an exponential rise. And I would probably argue that at least in our institution in New York, we're probably behind the curve, and kind of listening to all you guys here, it kind of really is inspiring to see kind of what we can do to be more efficient. And you really just heard two talks, which I think, each and, discussing what stem type to use and also discussing how to be efficient, I think are very exciting. But you can see how much is involved in that, right? Look at how much effort it takes to really be efficient in your ASC. Think about how much patient selection that takes. Think about the stem design, figuring out exactly what you need for each patient. That's a lot of work, a lot of effort, right? And I think that's going to continue to increase as we want to send patients home the same day. Kind of have to have all our ducks in a row. And unfortunately, patients are complex, right? I think, at least in my practice, when I first started thinking about sending people home, I was like, oh, I'll go through this criteria and this criteria. Suddenly, there's like no one left, right? It's like the bag is empty. There's no patients left, at least in my practice. And I think that that's a challenge. And at some point in time, we have to manage these comorbidities. We have to optimize our patients. In some respects, we kind of can feel like primary care physicians. And I think there's a huge effort that goes into getting patients ready to go home the same day. And at the end of the day, it's a lot of work on our part. And a lot of it can be on our staff. But a lot of it, I think, is the surgeon, potentially your PA, your NP, discussing with the patients going home, optimizing them, speaking with their cousin, their second cousin, figuring out a way to kind of get them to pick who's going to pick you up, what time they're going to come, are you going to Uber home, what's the size of the Uber that's going to pick you up. That's a New York City issue. And I think that that's something kind of we have to figure out, and it takes a lot of effort and time, right? And time is really the enemy, right? Everything is time. So today we'll talk about principal care management, in short PCM. And in 2020, basically, CMS kind of decided to allow 4 different codes for basically complex single high-risk conditions. And in 2022, CMS opened this to basically joint reconstruction. And the idea is to capture all the work we do before surgery and in a way that we can bill for this appropriately. And this is to acknowledge all that work we just discussed. And this is for the MD as well as their staff, and the medical doctor, DO, and the PAs or NPs are kind of in one category, and the clinical staff is in another category. And I think some of the important things is obviously documentation, very, very good. And I think that once this is set, it's kind of automated and it becomes a dot phrase, knowing the consent of patients and then document time spent. So in terms of going through kind of details, so who it is, so the MD and the NPs kind of fall into one category and the clinical staff falls into another when it comes to billing. And you can only bill, it's per month and it does not roll over. And the time spent is fundamental. So actually I'm gonna step over here because I wanted to actually read some of these details to you. It's on slideshow mode over here. But it really depends on the exact amount of time spent, and each is a 30-minute window. Sorry, let me go back one slide. Oh, thank you. They made it bigger for me. I'm always about the big text. Thank you. So the codes are 99424 and 99425. These are for the physician or the NPs or PAs. And this is the time spent per calendar month for those services preoperatively to optimize the patient. Then there are 2 codes, 99426 and 99427. And these are for the initial and then the additional 30 minutes per calendar month provided by the clinical staff. And this is under the direct supervision of either the MD, PA, or NP for those high-risk diseases. In this case, it's osteoarthritis and a patient requiring joint replacement. So feel free to take a photo if you want these codes. And then these are kind of the breakdown in terms of RVUs as well as potential costs. So if you're an RVU model, you can calculate the RVUs, and it's basically 1.45 for that initial code for the MD, an additional 1 RVU for the additional 30 minutes. And then for the clinical staff, it's 1 RVU and then 0.7 really for the additional 30 minutes that the staff may spend. And if you go through reimbursement rates, the numbers are there below. So it's about $81, a little bit over $100 for the MD doing that work, and then the same thing for the clinical staff. And those are the 2 different codes that you can add for. So you'd bill the first code for the first 30 minutes and then additional code for the additional 30 minutes. And it's different for the NP or the PA. Now, I guess that when you look at these numbers, you don't say, oh, wow, well, I'm not getting $1,000 for all that work. Maybe I should get that. So it's not that. It's I wouldn't call it a nominal number, but when you think of the volume we do and the effort that's already going into optimizing these patients, it can make a huge impact. And I will say, at least at our institution, we're trying to figure out a way to make this streamline kind of happen behind the scenes easily. And I think that's an effort in each of our institutions in figuring out how to do that. Because at the end of the day, if you're doing this, then sitting down, then coding and billing, I think it can be challenging. So I think kind of the feel empowered to figure out a way to make this more streamlined. So the question also becomes, when do you do this? So basically, if you indicate a patient for surgery, then between that day and then the day before surgery, you can't do this the day before surgery, that's the window for PCM, right? So it's got to be not the day of the consult and not the day before or the day of surgery. That's actually bundled into that care plan for the surgical procedure. So that's the window for PCM. So it could be a year between those two, and you can bill for every month, right? It's per monthly billing like we discussed before. This is the documentation and consent. Feel free to take a photo of this, but it basically goes through and outlines for the patient that this is what's being done, this is the plan and what we're doing for the patient, and that they acknowledge the fact that you are potentially billing for these interactions and discussions with them, and that this may be a separate billable code for them, and that they can opt out of this anytime. That's just something to keep in mind, to just document and consent appropriately. So typical documentation, I don't think is kind of, I think we all know this stuff, the diagnosis, the planning, what's done. But I think what is interesting is the things you can do, I think matter, right? It's not just what size Uber, right? It could be that complex case. I had to template it, discussion with the implant rep, figure out which implants to order in. We did all this pre-op templating. And discussion, right? That's time spent on this patient's preoperative care, right? That can be included in the time you calculate for this stuff. Same thing with your staff. If they're on the back end doing things for that patient, trying to figure out social work issues, figuring out how to optimize them better, that's time spent. And it's worth calculating it and kind of going through this. And this is the kind of comprehensive care plan kind of criteria that Medicare likes to know that you're working on these things, and kind of a lot of the stuff falls into those categories. So a few tips. So know the PCM window, right? You want to make sure if you're spending time appropriately, don't do it the day of surgery, right? That won't count. It's monthly, doesn't roll over. It's not like old AT&T minutes, right? It's just, it's per month and calculated. The time spent is 30 minutes, right? So I think many times it's way more than this, honestly. So really it's kind of almost maxes out. So just kind of calculate that and make sure to document it effectively, calculate it effectively. And then if you're gonna mix staff, if you mix the MD and PA time with the staff time, then you're gonna have to bill at the staff level code. It's not a huge difference, honestly, as long as you're billing the code, but it's something to be aware of. And I think most of the work counts, right? So consults, labs, templates. I was just here between meetings texting about some PJI on a lady that is, surgeries next month, right? That's time I just spent, and it's frustrating, right? But that's time that we spend on all our stuff. So in conclusion, reimbursements are declining and the burden remains high, right? Think about all the work we do for the patients. We can be reimbursed for this work. Medicare acknowledges that. It just has to be done appropriately and understand the time monitoring burden. Thank you.